Good afternoon, and thank you for having me here. It's really truly a pleasure to speak to you today about how to optimize Xofigo in the management of patients with advanced prostate cancer in our clinics and in our day-to-day practices. The talk itself is broken down into a couple of different sections. First, we go and start to have an evaluation of the kind of burden of castration-resistant metastatic prostate cancer. We then go in to have a little bit of a discussion around the implication of site and burden of metastases as it relates to progression-free and overall survival. We then introduce the class of alpha therapy as a mechanism of action, review the ALSYMPCA data, which is the phase 3 randomized trial that led to the FDA approval of radium, go through a potential proposed algorithm on how to manage these patients and layer in radium based on our clinical experiences, and then we end with a case. This really is somewhat of an informal program, so this will probably be about 45 minutes in all, and I hope to generate some discussion around disease state identification, therapeutic layering, and then how we kind of manage this patient population as really the gatekeepers of this disease in patients with advanced prostate cancer. Despite Samir's very eloquent presentation on the use of MRI and active surveillance, the vast majority of patients who have a diagnosis of clinically localized prostate cancer still undergo some form of definitive local therapy with an intent to cure, either usually in the form of radiation-based treatment options or surgical removal of their prostate gland. Of those, unfortunately, up to 30% experience a recurrence of their disease. That disease recurrence is usually heralded by a rising PSA at some long time interval from the initial diagnosis and treatment. In the U.S., the management of that PSA-only recurrence in the non-metastatic setting is almost universally treated with the use of a GnRH analog, either alone or in combination with an oral anti-androgen. The median duration of effectiveness of this therapy is only brief, unfortunately, only between 1 to 5 years on median. Universally, these patients go to progress. They develop rising PSAs with castrate levels of serum testosterone. And if they don't die from other comorbid diseases, ultimately go on to develop metastases and then subsequently die from their disease, making prostate cancer the second leading cause of a cancer-related death in American men. Currently, based on some pooled data analysis, the overall survival of the entire group of patients with mCRPC, which is universally viewed as an incurable condition, is on average about 22 months. We've made some substantial strides with respect to that overall survival, as we'll see in the last 6 to 7 years. The management in general of patients with advanced prostate cancer has changed dramatically in the last 15 years. Prior to 2004, this disease was treated primarily with palliative intent. These patients oftentimes had very shortened progression-free and overall survivals. They had rapid progression of their disease. These patients were those that oftentimes were widely metastatic at the time of their diagnosis. They went on to ultimately receive hospice evaluations, morphine drips, and ultimately died quickly from their disease. In 2004, Tannic published the TAX-327 trial. This trial was really the first trial to demonstrate an improvement in overall survival to the use of Taxotere compared to the then standard of care mitoxantrone in the management of patients with advanced prostate cancer. And this is exceptionally important because this really represents a paradigm shift in the management of this patient population. This represents a shift away from palliation and end-of-life concerns and now more towards focusing on improving overall survival and bettering outcomes in patients with advanced prostate cancer. From 2004 to 2010, there were limited new therapeutic options available for management. The majority of these patients were seen by us as the gatekeepers, the urologists. They were given their 6-month Lupron injection, oftentimes sent out, wait till their PSA rises and they develop symptoms, and then sent on to medical oncology. In 2010, this paradigm shifted yet again. From 2010 until current, we've had 5 new therapies approved for the management of patients with advanced prostate cancer. They all significantly improve overall survival. They're all very well managed from a toxicity perspective. And they're all FDA approved in the US. This really represents a time for us as urologists to continue to manage and kind of take back the care of patients with advanced prostate cancer. The challenges are that with 5 new recent FDA-approved therapies in the last 6 years, with several more expected to be approved in the next 1 to 3 years in both the M0 as well as the M1 space, this becomes a very complicated space of the disease to manage. It's further complicated by the fact that our governing bodies, the NCCN, ASCO, AUA, ESMO, the Canadian Society on Neurology, have really given us very limited guidance in which patient to use which drug at which time. This makes it exceedingly challenging for us to figure out which drug to start in which patient. The St. Gallen's Conference on Prostate Cancer recently published a consensus statement around the management of this patient population. What they suggested was that each of these patients should try to avail themselves of each available therapeutic option along their disease continuum. We've taken this to mean to try to find the right patient with the right drug at the right time. To do this, though, we have to really kind of understand the biology of the disease, the implication of the sites of metastases on progression-free and overall survival. We also have to understand the implications of the microenvironment and its role in tumor progression and development over time. Advanced prostate cancer is a very genetically heterogeneous disease. It's one that has multiple phenotypic presentations, and those various phenotypic presentations can have implications with respect to progression-free and overall survival, and may even impact various therapeutic choices. This is data which was published recently in European Urology, which assessed the survival based on site and burden of disease in over 3,500 patients with castration-resistant metastatic prostate cancer. And what we see are a couple of trends appearing. In the upper line, we see that those patients with lymph node predominant metastases tend to have more of an indolent course. These patients tend to have a prolonged progression-free and overall survival. These patients in this study had an overall survival in median of about 43 months. And these are those patients that tend to do well with sequential therapy, starting usually with immunotherapy, working through several oral oncolytics, layering radium in, then going ultimately on to chemotherapy. In contrast to that, those patients who have visceral disease alone or visceral disease in combination with bone disease tend to have a very aggressive form of this disease. They tend to progress rapidly. Their overall survivals oftentimes are shortened. And on average, their median survival is somewhere between 14 to 16 months. These patients are often best managed not with sequential oral therapy or immunotherapy up front, but oftentimes best identified with initial chemotherapy and then kind of layering in the oral oncolytics on the back side. The majority of patients, however, that we see with this disease are actually somewhere in the middle. The majority of these patients actually have bone-predominant disease, and these tend to take more of an intermediary course. These patients, on average, have a median overall survival of about 24 months, and this gives us opportunities to layer in various therapeutic options. What this slide kind of demonstrates and highlights is the role of not only the site and burden of disease, but also the potential role of the tumor microenvironment in disease progression over time. So what's the true incidence of bone metastases in patients with advanced prostate cancer? Well, this is data from 4 large randomized phase 3 trials, the 301 trial being the post-chemotherapy trial for abiraterone, the AFFIRM trial certainly being the post-chemo trial for enzalutamide. We talked about the TAX-327 trial already, and then the SWOG 9916, which is the trial looking at the use of estramustine versus taxotere in patients with castration-resistant metastatic prostate cancer. And the incidence of this disease in the bone is somewhere at least about 90% in most studies, suggesting that the vast majority of patients we see with advanced prostate cancer will have some degree of bony involvement. Does the bone have a role in disease progression over time in patients with advanced prostate cancer? Well, this was a question that was kind of asked and answered in a very elegant fashion by Gundam in a paper he published in Nature in 2015. This is kind of confirmation of the so-called seed and soil hypothesis. What he did is he looked at 10 patients who had castration-resistant metastatic prostate cancer, and he took over 50 metastatic sites and 5 primary tumors and conducted whole genome sequencing of these tumors. His goal here was to really try to identify a metastatic map of these patients. And what he found was that subsequent metastases were actually born from pre-existing metastases and not from the so-called mothership, meaning that existing bone mets led to the development of subsequent bone mets and in later stages of the disease, ultimate to visceral involvement, suggesting that the bone microenvironment certainly plays a big role in disease progression and progression-free and overall survival over time, and also potentially presenting the bone microenvironment and the bone itself as a ripe therapeutic target for novel modalities. Well, we kind of addressed this a little bit in some of the previous slides, but just the presence of bone mets in and of themselves decrease survival in patients. This is a Danish cohort study which looked at 23,000 patients and assessed their survival in that patient population, stratified by the presence or absence of metastases at the time of diagnosis. And as highlighted in the kind of middle graph there, their 5-year survival was about 56% in the localized group and 3% in the bone mets group without skeletal-related events. That 3% value dropped to 0.7% in those patients who had bone mets plus an SRE, again suggesting that the presence of bone disease is a negative prognostic indicator and adversely affects progression-free and overall survival and may be a target for therapeutic intervention. Fred Sod took this kind of one additional step and asked not only the presence of bone metastases, but the presence of skeletal-related events as it relates to the presence of bone metastases. Does it do two things? Does it, one, negatively impact that patient's quality of life? And two, does it significantly increase the risk of death from prostate cancer? He did an analysis of a Medicare SEER database over a 7-year period. He looked at 43,000 patients, and he used 3 validated instruments to assess quality of life impact: the FACT-P, the European Validated Instrument on Quality of Life, and the BPI. He found that the presence of any skeletal-related event significantly decreased quality of life in this patient population. When he then assessed the impact of SREs on survival, using the non-metastatic patient population as the cohort baseline or the reference cohort, he assessed those patients who have bone mets and no SRE had a 6-time increased risk of death, and those patients who had a bone met and a presence of a skeletal-related event had a 10-time increased risk of death, suggesting that not only bone metastases, but the skeletal-related events associated with those bone mets dramatically decrease quality of life as well as significantly impact survival in patients with advanced prostate cancer. The final kind of question around bone mets as a topic becomes, does the presence of bone metastases significantly increase the cost to the system as it relates to the development of SREs? This is a kind of a paired cohort study which looked at 900 patients with bone mets and no SRE versus 900 patients with bone mets and a skeletal-related event. As you can see, the presence of any SRE significantly increased the cost or burden to the system, and with increasing severity of those skeletal-related events, there was an increased cost. So I think we've pretty well established the fact that bone metastases plays a negative role with respect to progression-free and overall survival. It potentially serves as a source, or not potentially, it does serve as a source for disease progression in patients with advanced prostate cancer. The development of SREs significantly increases patients' risk of death and dramatically negatively impacts their quality of life. And the burden on the system in these patients with advanced prostate cancer who develop an SRE is significant financially. It would seem, therefore, that we would be compelled to try to, as efficiently as possible, prospectively identify those patients who have the development of bone mets. Unfortunately, as a collective, the urologists and medical oncologists, we haven't historically done a very good job at identifying that M0 to M1 transition. And that's really important because historically, we haven't had a bunch of options to offer these patients. Now we have 5 new options, all of which improve overall survival, all of which have minimal toxicity, and all of which are approved. So if we're not prospectively identifying these patients in an aggressive fashion, we're really missing a window of opportunity to deliver therapies which improve life, and not only from a quality, but from a quality perspective. This is data from Evan Yu's Enthuse trial. This was a trial which kind of confirmed the fact that we don't do a very good job at identifying those M1 patients in a prospective fashion. This trial looked at the use of a medication called zybotetam. And they attempted to see if the use of zybotetan delayed the progression to M1 disease, as well as also improved survival in patients who had M0 castration-resistant prostate cancer. Ultimately, this trial was a negative trial, and it failed at least in part because of the high rate of screen failures. 45% of patients who were screened on this trial actually were screen failures. And the most common cause for screen failure was the identification of metastatic disease in patients who were previously thought to be M0. And that suggests that of those people who referred into this trial at the University of Washington in Seattle, we didn't screen them very effectively. And that includes both urologists as well as medical oncologists. So, and I think at least in part, again, this is due to the fact that as urologists, we haven't had many opportunities to deliver life-extending care to this patient population, with the exception of the last kind of 4 to 5 years. And two, our governing bodies, again, haven't given us a lot of guidance as to which patient and when to screen them for the development of M1 disease. Well, Dave Crawford recognized this as a knowledge gap, and he convened a multidisciplinary consensus panel of urologists, medical oncologists, and radiation oncologists called the RADAR Group. And he charged them with trying to develop a schema around which we can more effectively identify that M0 to M1 transition. And they published the RADAR guidelines initially in 2014 in the Gold Journal. It's been updated now, I think, 3 times. The initial guidelines recommend that in patients who are having quarterly PSAs checked, that, and they have castrate levels of serum testosterone, once their PSA reaches 2, they should have a baseline CAT scan and bone scan. If that baseline CAT scan and bone scan is negative at a PSA of 2, it's recommended that that is then repeated at a PSA of 5. If the if the CT and bone scan are negative at a PSA of 5, it's then recommended that it's repeated on a doubling of the PSA thereafter, 10, 20, 40, et cetera. This is important because it really represents the first framework within which we can help make decisions around which patient we're going to screen, when, and why. And this is, I don't want to go as far as saying groundbreaking, but it helps us make better decisions on who we screen, again, to identify that transition from M0 to M1 as quickly as possible. So in summary, from a bone metastases perspective, we've outlined that obviously the vast majority of patients with advanced prostate cancer, over 90%, have bony involvement. We suggested that we don't do a particularly good job at prospectively identifying those patients, and at least a third of those patients who are thought to be M0 actually have M1 disease. Certainly bone met serve is one of the major causes of death in patients with advanced prostate cancer. And symptomatic skeletal-related events, the presence of fractures, the presence of spinal cord compression, the need for surgery or radiation should really try to be avoided from a quality of life as well as a survival perspective. And it would be nice to be able to have a therapy which is targeted or directed towards not only the bone microenvironment but also the prostate tumor itself in an attempt to address all these underlying concerns. Well, the bone certainly offers a valuable treatment opportunity that can influence disease progression and long-term survival. I think we've made that case pretty effectively in this patient population. And when we talk about alpha therapy as a class of therapies, it's been around for a long time, decades, however, but it's somewhat new, I think, to most of us in the room. Historically, this therapy really has been meant to kind of mean you're taking alpha particles and either chelating or conjugating them to tissue-specific or cell-specific antibodies. The idea is that these antibodies then they bind to the cell or tissue of interest, and the radiation is delivered to induce tumor-directed kill. Over the past decades, there's been marked improvement in our ability to more adequately and more accurately conjugate or chelate these antibodies to alpha particles. We've identified multiple potential new tumors that may benefit from alpha particle therapy. We've uncovered and identified an increased number of isotopes which might be utilized for the management of patients with advanced cancer. And we've kind of better understand some of the basic kind of pathophysiology around the natural uptake of these particles, certainly as we see with radium. And we'll see that as we kind of go through the Alsimca data and the radium mechanism of action, we'll see this really has established a proof of principle of a whole new class of therapeutics with a unique mechanism of action from one we've ever seen historically. And this is one, certainly in prostate cancer, which is not only a unique mechanism of action, but one that is a unique opportunity to improve survival in this patient population. So alpha particles act through the distribution of high-intensity linear energy. That high-intensity linear energy induces double-stranded DNA breaks over a very short distance. When we say short distance, it's about 10 to 12 cells. Those double-stranded DNA breaks are very difficult for the cell to repair, and even a relatively small number of hits from an alpha particle induces cell death. That cell death occurs through apoptosis, cell cycle arrest, as well as necrosis. This is a cartoon which kind of highlights the precision with which alpha particles can act when compared to beta and gamma particles. We see that we achieve local tumor control, local tumor kill with minimal impact on surrounding normal tissue. This minimizes toxicity and maximizes outcome in this patient population, and represents a new approach, a whole new class of therapeutics, which we now have to consider in the care of patients with advanced prostate cancer. So when we talk about radium in particular, radium is a calcium mimetic. It's something that's taken up by hydroxyapatite in bone that's being actively remodeled. We know that in patients with bony metastases that the bone is undergoing a constant process of remodeling through both osteoblastic as well as osteoclastic overactivity. And hydroxyapatite takes up and binds this calcium mimetic radium and incorporates it into the bone interstitium where it can affect its tumor kill. This rapid bone turnover is driven both by tumor microenvironment at the level of the bone as well as from soluble factors from the level of the prostate tumor cells themselves. The mechanism of radium acts in two fashions, first of which it inhibits tumor growth and by inducing double-stranded DNA breaks, and secondly, it suppresses tumor-induced abnormal bone formation. So we also should be reducing our risk of skeletal-related events because, as we know, that remodeled bone by osteoblastic overactivity is much weaker than so-called normal bone, increasing patients' risk of fracture, et cetera. So this is the schematic or the schema for the ALSYMPCA trial, which is the phase 3 randomized trial that led to the FDA approval of radium-223 in the management of patients with symptomatic skeletal metastases and no visceral metastases. This trial had 922 patients, all of whom had confirmed symptomatic CRPC. They all had greater than or equal to 2 bone metastases. No visceral involvement. Lymph node involvement was permitted as long as that lymph node involvement was less than 3 centimeters in the largest axis. These patients were both post-doxytaxel as well as those patients who were considered to be quote-unquote unfit for doxytaxel. These patients, the unfit group, include those patients who were truly unfit from a performance status or marrow perspective, as well as those patients who simply refused the use of chemotherapy. They were stratified by total ALP, the use of bisphosphonates, as well as the use of prior doxytaxel. And then they were randomized 2-to-1 to receive drug versus placebo. It's important to point out that they received, in addition to the drug versus the placebo, they also received best standard of care. And best standard of care on the ALSYMPCA trial was defined as anti-androgen therapy, usually Lupron or Eligard or some GnRH analog, the use of a bisphosphonate in most cases, potentially Xgeva as well, and also potentially the use of external beam radiation therapy in patients who had symptomatic bone mets. So it's important to understand that we can use concomitant external beam radiation therapy as well as radium simultaneously in this patient population because that's the way it was done on trial. These are the demographics from the ALSYMPCA, and you can see that they're, for the most part, well matched with respect to age, baseline ECOG. And the extent of bony mets was significant. Most of these patients had 6 or more metastases, and 40% had, what would be kind of classified as a super scan. This is the Kaplan-Meier estimates of overall survival. As you can see from this Kaplan-Meier estimate, that those patients receiving radium had an overall survival of about 14.9 months, compared to those patients on placebo of 11.3 months. That's a 3.6-month improvement in overall survival. And their hazard ratio is 0.7, which is a 30% reduction in the risk of death associated with those patients receiving drug compared to those patients receiving placebo. And I think, which is important to mention, the radium group significantly improved all secondary endpoints. Those secondary endpoints being improvement in quality of life and also the reduction in the risk of skeletal-related events. If we look at the toxicity of the therapy, it's for the most part a very well tolerated therapy. This is looking at the grade 3 and 4 hematologic side effects. We tend to focus on those grade 3 and 4 toxicities, as those grade 3 and 4 toxicities tend to be the therapy-limiting toxicities. As you can see from both an anemia perspective, thrombocytopenia, as well as neutropenia, they're fairly well matched with respect to the treatment group compared to the placebo group. This is an important slide, and it's an important slide because it really distinguishes, this therapy as a novel therapy really aimed at improving survival, and separates it clearly from therapies traditionally which have been associated with quote-unquote supportive care or palliation. This is one that really stands in a class by itself and should be thought of much differently and treated much differently than those previous treatments have been. It should stand alone and should be used much like your oral oncolytics are used to attempt to improve survival, reduce SREs, and improve patient quality of life. This is not samarium. This is not strontium. This is not utilized, as a last-ditch effort to, palliate pain. And it's not something which is going to be used, as a supportive agent like zoledronic acid or denosumab. And this is a slide I threw in actually about an hour ago. And the reason I put it in about an hour ago is because it's something that I think is an important concept. On trial and on their label, they talk about symptoms. And they took symptoms on trial to include pain. About 50% of patients required narcotics, about 50% of patients were on NSAIDs, and you had 2% of patients on that trial who had no pain at all. They required nothing, no NSAIDs. And I question how many of those true Alzheimer's patients are going to be, meaning by the trial, are going to be available to us in our clinical practices if we're finding this disease much, much earlier. So, to me, symptoms are much more than pain. Symptoms really are going to be a reflection of the burden of disease as it relates to the performance of that patient and the impact on that patient as a whole. To do this, we have to kind of really look deeper. We have to kind of peel back the layers of the onion, so to speak, to understand how this progressive disease is impacting patients' quality of life. We can look at their ECOG. Are they still doing things that they do day to day? If not, that certainly is an indication. We can look at their appetite. We can look at weight loss. We can look at worsening fatigue. The presence of anemia certainly can potentially be viewed as a symptom, in my opinion. What I really want you to start taking away from this slide and from the talk in general is that symptoms doesn't always equal pain, right? That there are symptoms which are clearly reflective of the burden of this disease, which are independent from pain, and make these patients eligible to receive radium. If we wait sometimes till they have narcotic requiring pain in a patient that we know is going to require 5 months or 6 months of therapy, then we've missed potentially a window sometimes to deliver that total course of therapy, which is the course which is really going to achieve the maximal benefit and outcome as it relates to survival and reduction of SREs and improvement in quality of life. So that speaks to, how do we integrate this? How do we kind of layer this in? Some of this depends on your access to it. In the US, we've taken to layer this over our oral oncolytic therapy. And we do that because we know that based on the 302 trial, and we know that based on the PREVAIL trial, that these patients on oral oncolytics tend to progress around 11.2 months on median, some a little bit earlier, some a little bit later. But about that time, that's a perfect time to start folding in these medicines like radium with a unique mechanism of action to complement your existing oral oncolytic to maximize tumor kill and maximize, in theory, patient outcome. I understand that there's some challenges in terms of access to layering in parts of Latin America, in which case then you might want to consider giving that the radium up front and then going to an oral oncolytic on the back end. We can kind of talk through potential scenarios, if you'd like, once we're through the deck. So in summary, from an MOA perspective, as well as radium in general, this is really a novel therapy. It's the first and only targeted therapy in its class. as we discussed, it exhibits a dual mechanism of action by both inhibiting tumor growth and suppressing abnormal bone formation. It improves overall survival in patients with castration-resistant metastatic prostate cancer. It's safe and well tolerated, and really opens up the gate for investigation of new and novel alpha therapeutics for other disease states, including prostate. As an overview of the ALSYMPCA trial, there's an improvement in survival of 3.6 months. There's a 30% reduction in the risk of death. All secondary efficacy endpoints, as we've mentioned, were improved in those patients receiving drug compared to those patients receiving placebo. And the overall incidence of adverse events was consistently lower in the radium 223 arm than the placebo arm. That's a profound statement. And the only other trial I've ever seen that in is actually the AFFIRM trial, the post-chemotherapy enzalutamide trial, suggesting that this drug is very well tolerated. So how do we follow patients on Xofigo therapy? Well, this is a chart from the Consensus Panel on Advanced Prostate Cancer conference, and they gave us some recommendations on how we should evaluate patients who are on radium therapy. They start certainly looking at the clinical symptoms. Patients have to be appropriate for the use of the therapy to begin with. We talked about pain certainly being one of those symptoms, but we talked about those symptoms being much more sophisticated than pain. From a provider perspective, that requires us to spend a lot of time and really get to know our patients, know their hobbies, and know the impact of the therapy on their performance status. They recommend we check an ALP, an LDH, a PSA. And we have to have baseline parameters which allow them to initiate therapy. Their hemoglobin has to be above 10. We have to have an absolute neutrophil count above 1.5, and platelets above 100,000. They recommend a baseline bone scan and CAT scan. I do a baseline bone scan and CAT scan primarily to get a baseline bone scan to try to assess response after 6 therapies. And the CT scan I utilize primarily to make sure they don't have visceral involvement prior to initiating treatment. We repeat their laboratory values from a heme perspective every month, usually a week prior to their treatment. And if patients don't recover their subsequent values within 6 to 8 weeks, then usually we discontinue therapy altogether. At the end of therapy, after 6 months, we repeat usually a CAT scan and a bone scan and follow them like that. On the ALSYMPCA trial, we know that there are certain clinical pathologic factors which predict outcome to various therapies in patients with advanced prostate cancer. And so what Sartor tried to do was he tried to see if we could try to find those clinical pathologic variables that predicted survival in patients on the ALSYMPCA trial. So he did a subset analysis looking at ALP, LDH, and PSA and published that data recently. This is the data looking at a 12-week ALP response in patients receiving radium compared to those patients receiving placebo. Not surprisingly, you had a significant improvement in those patients receiving radium when compared to placebo. Not only that, you appeared to have a potential survival benefit. That in those patients receiving on the radium arm, their overall survival was 17.8 months versus 10.4 months in those patients who did not have an ALP response. This suggests that ALP at least may potentially be utilized as a marker or a measure of disease. He then looked to see if ALP response at 12 weeks actually predicts outcome in patients receiving radium, and it seems to predict outcome. However, the kind of company line still is that, it's not specific or sensitive enough to use as a marker per se of this disease. He then looked at LDH in a similar fashion. The LDH was less responsive to radium therapy. It did respond, but to a lesser degree. But he did see similar responses as it pertains to overall survival. That those patients receiving drug had a 19.5-month overall survival compared to 14.5 months in those patients receiving placebo, but that there was no trend towards predicting overall survival when it came to LDH. And PSA was not a useful marker at all when it came to the evaluation of patients' response to radium. So, oftentimes these patients will have a flare phenomenon. It was seen in about a third of patients on the ALSYMPCA trial. That flare phenomenon, in our experience, most commonly occurs around a 3 to 4 month period. This is something where we can see increased pain. We can see a change in the bone scan. They reported on this recently as well. This is something that we should make sure that there's progressive disease prior to switching therapies. This is not something you want to stop simply for a flare phenomenon. And I would suggest that we try to treat through this to make sure that we get all 6 doses in to achieve the maximal benefit from a survival perspective that's possible. So how do we monitor these patients? Well, it's important, as we just kind of alluded to, that patients who have either a PSA, patients should be stopped or taken off therapies for really 2 of the 3 following, either a PSA progression, a radiographic progression, or clinical deterioration. We, generally speaking, treat through PSA progressions. We really look at either clinical or radiographic progression of their disease. We may be able to utilize ALP in this setting. If we don't see an ALP response or the ALP goes up, that may be a clue that these patients aren't responding quite as well. Again, we want to make sure that we don't miss transition points. If these patients aren't responding, we want to switch them on to a therapy which is going to improve their survival. Maybe that's chemotherapy in this case. How do we optimize this in our clinics? And it's important to understand that some of our initial treatment decisions can impact what our subsequent decisions are going to be. And we propose a little bit of an algorithm here for management. So first off is we have to identify them, right? As a collective, we've had a challenge accurately identifying those patients with mCRPC. We looked at the EVANU data. We've looked at multiple other kind of data points in both the community as well as the academic setting. And now we have the RADAR guidelines to help us identify that disease more effectively. But we have to be looking for it as urologists, or we're going to miss it. If we don't look for it, I don't think we're serving our patients well. So once we proactively screen, if these patients have symptomatic disease and they have bone-only disease, and they're considered to be quote-unquote lower risk. Well, how do we define lower risk? Lower risk, generally speaking, is a longer duration of androgen deprivation therapy. So those patients who are on androgens for more than 12 months, these patients are a subset of patients who tend to do better from all therapeutic outcomes than those patients who develop castration resistance inside 12 months. Those patients who have a longer PSA doubling time, and those patients who have a lower disease burden, usually 5 or less bone metastases. These patients are perfect radiant patients, in my opinion, and oftentimes we utilize this therapy in that setting. And if they progress, they certainly go on to the use of docetaxel and oral oncolytics. Most commonly in our practice, we use oral oncolytics next, then followed by taxane-based chemotherapy. If they're a little higher risk, and we define higher risk in this setting as those people who were on ADT for a shorter period of time, again, less than 12 months, those people who have a higher burden of disease, usually 6 or greater bone metastases, or those people who have a rapid PSA doubling time, usually inside 9 months. Usually these patients are probably best served with upfront chemotherapy. These are those patients who are going to progress rapidly and oftentimes die from their disease. And we don't want to miss a window of opportunity to introduce a cytotoxic therapy, which may improve survival. Then certainly if there's an opportunity following chemotherapy, we can introduce the use of oral oncolytics and or radium, depending on the sequence, or potentially in a layering fashion. Those patients with visceral disease, they should really go on to Taxotere or Jevtana as first-line therapy, and then ultimately on to an oral. Enzalutamide tends to be the oral of choice in patients with visceral disease because there's some data looking at, in the AFFIRM trial in those patients with visceral involvement. So how about those patients who have asymptomatic or mildly symptomatic disease, which hopefully will be the majority of the patients that we're seeing, right? So if we're aggressively identifying these people, we want to find them when they're asymptomatic. We don't want them walking into our clinics with bone pain or reduced performance status and an ALK Phos of 600. If these patients have bone-only disease and they're lower risk, oftentimes, we put these patients on immunotherapy or Sipuleucel-T, plus minus the use of an oral oncolytic after that. And then we usually layer in radium over top of that oral oncolytic. Certainly as they progress, they have to go on to first and second line chemotherapy, which is Taxotere and Jevtana in this setting. For those patients who have higher risk bone disease, we usually again start primarily with the first and second line chemotherapies, followed by the use of oral oncolytics and radium following chemotherapy. And those patients who have visceral disease, these are those patients who go down in flames, even if they're lower risk. I have enzalutamide here as a potential option, but my advice would be to really go to chemotherapy up front, as a natural history of these patients, unfortunately, is a rapid progression-free and overall survival. And certainly chemotherapy is the mainstay of management for this patient population. And those visceral disease who have higher risk, docetaxel, and then Jevtana. So, the majority of these patients, as I've kind of outlined, are going to have bone metastases. And the majority of these patients are going to be potential candidates if we time them and find them accurately within their disease continuum for the use of radium in the management of their care. The question, the challenges to us becomes we have to kind of aggressively identify them, and we have to, think about this therapy, one, in an improvement of overall survival perspective and not in a palliation perspective. And two, we have to kind of aggressively identify the M0 to M1 transition. So radium should be used early in men with mCRPC and symptomatic bone metastasis before visceral mets develop. If we wait too long, we're going to miss that window of opportunity, right? This is a therapy which is given over 6 months, so we need significant lead time to allow delivery of the entire course of treatment. We've been over a lot of this already, but all patients in the Alcimca trial were also treated with best standard of care. Palliative external beam can be used concomitantly with radium treatments. And really, there's no concerns around the concomitant use of bisphosphonates or denosumab in these patients, or with the use of concomitant oral oncolytics. And docetaxel certainly can be given safely in a post-radium patient. Patients with advanced, castration-resistant metastatic disease, those patients who have been through multiple lines of therapy, those patients who have, higher ECOG, performance status, higher LDH, PSAs, ALK phos at the time of initiation of radium, are less likely to receive the entire course. This puts them at risk, obviously, for disease progression and suboptimal therapy. So I just included one case here. This is a case which was presented at ASCO. It's looked at a 69-year-old man from Beaumont, Texas, who had high-risk localized disease. His PSA was 4.6. Unfortunately, he had Gleason 9. But he did have a margin negative, node negative resection, and underwent salvage radiation therapy for a PSA-only recurrence about 2 years after his initial diagnosis. Unfortunately, even after salvage radiation, within a year, he developed a rising PSA. That rising PSA was in the non-metastatic setting, as you can tell from the bone scan and CT. And was managed with intermittent androgen deprivation therapy. As all of these patients do, if they live long enough, they ultimately go on to develop a rising PSA with castrate levels of serum testosterone, and that caused them to be managed with biclutamide withdrawal, Cipusel-T, and Abi, which he was unable to tolerate. By the way, as an aside, this is a case that was presented at ASCO. We don't routinely utilize Castex or biclutamide in our practice in this patient population for a multitude of reasons, not the least of which is that there's never been a documented survival benefit in patients with mCRPC in use of biclutamide. And as important, that the use of biclutamide in these patients oftentimes precludes them for enrollment in M0 clinical trials, which is a big part of our practice. So we want to make sure that we're not giving them something which has potential toxicity and no survival benefit. Nonetheless, this is an ASCO slide, so it was delivered there, so I'm presenting it as it was delivered. And this is unfortunately, he had bone scan progression. As you can see, in May of 2014, his PSA was 14.3 at that time. He underwent his 6 injections of radium, and his follow-up bone scan after his 6th injection looks markedly improved compared to his initial bone scan. Unfortunately, despite this, he had a PSA progression where his PSA went up to 52.8. Not only did he have a PSA progression, but he had a scan progression as well. So the fact that he had progression on his bone scans and CT suggested additional therapy. At this point, we utilized enzalutamide due to his previous Abi intolerance. He responded briefly to that and unfortunately had rapid progression of his disease, but ultimately responded well to docetaxel. in a cytotoxic kind of regimen. This is a typical, I think, case where we see the positioning of radium prior to chemotherapy, which is where I would advocate its use from a couple of different perspectives. One from a marrow perspective, meaning the bone marrow is a little bit more robust prior to chemotherapy, and the performance status of these patients is a little bit better. And so this is classically where we try to position this therapy in our patients with castration-resistant metastatic disease. If it's given in the post-chemo setting, oftentimes they can't tolerate or they don't receive all 6 injections. And that is not so much from a toxicity perspective, but just that their marrow is beat up. And oftentimes, those patients have been kind of at the end of their therapeutic continuum, as opposed to, it being a reflection of the toxicity of the therapy itself, simply that their disease is just progressing fairly rapidly at that point. I think that's it. I thank you very much for your attention and your time. I appreciate the invitation to come down. I would be interested in entertaining any questions about this. I think that, as urologists, we really are kind of the gatekeepers of patients with prostate cancer from diagnosis and now potentially through death. And so I want to make sure that we continue to take care of this patient population. And if there are any shared experiences we can review or discuss, I'm happy to do that. No? Okay. Thank you very much.